Hello everyone, this is Dr. Sangeeta Chaudhary and once again I welcome everybody to my class. In my today's class, I am going to discuss about insulin, its initiation and intensification, which is very important from practical point of view. So this will be the flow of my presentation, a little bit about history of insulin, then physiological insulin release, types of insulin, when to initiate, how to intensify, and regarding the titration of insulin doses and monitoring of the patients. Insulin is the most powerful agent we have to control blood glucose. It is the miracle discovery that saved many lives. Before the invention of insulin, diabetes was a death sentence, and after insulin is introduced, it has become a manageable condition. Insulin release. Insulin is released as a peptide hormone. It is released as a precursor which undergoes proteolytic cleavage to form a dipeptide. It has two chains, alpha and beta chains, which is connected by a C peptide. It is the connecting peptide. Insulin is released in two phases. In the first phase, insulin is released in response to raised blood glucose level, and in the second phase, there will be a slow, sustained release of insulin which is independent of blood glucose. So, as I said, normal insulin is secreted in two phases, phase 1 and phase 2. What happens in type 2 diabetes? In type 2 diabetes, first phase is missing. And because of absolute insulin deficiency in type 1 diabetes, both the phase of insulin release, that is phase 1 and phase 2, are missing. Types of insulin. So, what are the insulins we have? These are human insulins and these are insulin analogs. So in the human insulin, we have short-acting insulin, that is regular insulin, and intermediate-acting insulin, that is NPH or isophane insulin. And we also have premixed insulins of NPH and regular insulin. In the insulin analogs, we have ultra-short-acting or rapid-acting insulins, Lispro, Aspart, and Glulysin. And long-acting insulins, we have Glargine, Detamir, and Digludec. Again, we have premixed analogs of LPL with Lispro and NPA with Aspart as well. What is the difference between human insulin and insulin analogs? Human insulins, they are just identical to insulin released from the pancreas, whereas insulin analogs, they are genetically modified, they are genetically engineered to form better insulins with better pharmacokinetic and pharmacodynamic profiles. Coming to insulin types and profiles, this slide is very important. Whenever we are prescribing insulin, we need to remember the action profile of different types of insulin. Rapid-acting insulin, Lispro, Aspart, and Glulysin, they start acting within 10 to 20 minutes. They reaches their peak by 1 to 3 hours, and the duration of action is 3 to 5 hours. For short-acting insulin, like regular insulin, the onset is within 30 to 60 minutes. It reaches the peak within 2 to 4 hours and duration 6 to 8 hours. Intermediate acting insulin, that is NPH, it starts acting within 1 to 2 hours and it peaks lasts for 4 to 8 hours, and then duration of action is 12 to 16 hours. Long acting insulins like Glargine and Detamir, they start acting within 1 to 2 hours. They don't have a peak, their action profile is very flat and action lasts for around 20 to 24 hours. For Detamir, it is usually around 16 to 20 hours, and for Glargine, it is 24 hours. Ultra long-acting insulin, that is Digludec. Digludec starts acting within 30 minutes to 1.5 hours. Its action profile is again very flat, flatter than Detamir and Glargine, and its duration of action is more than 36 hours. So this is a very important slides which we need to remember when we are prescribing insulins. This is the insulin time action curve. Again, it is the same thing which I have described just now. This is for rapid acting insulin. This is the peak of rapid acting insulin. This is short or regular insulin, and intermediate acting insulin, that is NPH, and this is the graph for longer or long acting insulins which do not have a peak. The action profile is like a flat line. When to initiate, that is very important. When to initiate insulin, who requires insulin actually? All type 1 diabetes patients. Type 2 diabetes uncontrolled on other therapies, gestational diabetes, stressful conditions like if somebody is undergoing surgery, some acute illness or infections. In cases of acute complications of diabetes like diabetic ketoacidosis, hyperosmolar hyperglycemic state, those receiving parenteral or enteral nutrition, and secondary diabetes may be due to pancreatitis or diseases that reduces beta cell function or use of corticosteroids. So these are the situations when somebody requests insulin. There are many guidelines which will give us which will direct or guide us for use of insulin. Almost all the guidelines, they do follow the basic principles. So as per the AAC, that is American Association of Clinical Endocrinology, when to consider insulin therapy in patients with type 2 diabetes mellitus. The strong recommendation to initiate insulin is when HbA1c is more than 9% and the patient is symptomatic for hyperglycemia, with or without other antihyperglycemic agents, right? That means insulin can be initiated at the very beginning when the patient is having HbA1c of more than 9% and there is symptomatic hyperglycemia. Option for consideration as initial therapy in combination with one or two other antihyperglycemic agents when HbA1c is in between 7.5 to 9%. And for treatment intensification, insulin can be added when the HbA1c is, the target is not achieved even after 3 months of therapy. It may be monotherapy or dual therapy with OHA. Now, the recommendations by American Diabetes Association for initiation of insulin when HbA1c remains uncontrolled after 3 or more months of therapy with triple combination, right? HbA1c more than 10%, blood glucose, that is random blood glucose, more than 300 mg per deciliter, and symptomatic hyperglycemia. So these are the other indications for initiation of insulin. Now, how to initiate? As I said, there are a number of guidelines, but they do follow the basic principles of initiation of insulin, which is same. There is no magic formula for the calculation of insulin dose, because the patient sensitivity greatly varies. So the rule is we need to individualize the treatment, right? For every individual we need to think of a better option and better dosing, right? It is not like we have an universal protocol which we use for the treatment of diabetes, right? So what are the insulin regimens we can use? We can use basal regime, we can use twice daily regime, which is the conventional way to do it, then multiple subcutaneous doses, and continuous insulin delivery. Now, there are different guidelines, as I said, and I will mainly discuss about the guidelines laid down by ADA and AAC. So, initiation and titration of insulin by ADM. So, at the initiation, ADA usually prefers us to start with basal insulin, like basal analog or maybe bedtime NPH insulin. If we are starting with basal analog or bedtime NPH, we can directly start with 10 units, or we can start at a dose of 0.1 to 0.2 units per kg per day. And then we will be up titrating the dose depending on the fasting blood glucose level, fasting plasma glucose level. Okay, we need to increase the dose every third day. And if there is hypoglycemia and the cause is not known, cause is not clear, then lower the dose by 10 to 20%. And then assess adequacy of insulin dose at every visit. If HbA1c remains above the goal, then what we can do? We have two options. If HbA1c is above the goal, we can start with GLP-1 receptor analog or dual GIP and GLP-1 receptor analog. If the patient is already not on these drugs, we can start with these drugs. Otherwise, we can intensify the basal regime with initiation and titration of prandial insulin. Now, how we start prandial insulin? There is something known as basal plus regime. That means along with the basal insulin, we will start prandial insulin with the largest meal of the day. That means only one time prandial insulin we will give with the largest meal of the day. And how we should initiate it? We can initiate at a dose of 4 units per day or 10% of the basal insulin dose what we are using, right? So this is the dosing of prandial insulin which we will start in the basal plus regime. We need to increase the dose by 1 to 2 units or 10 to 15%. Twice weekly we can do that. And if there is hypoglycemia and the cause is not very clear, then we need to reduce the dose by 10 to 20%. Next, if still HbA1c is above goal, that means even after initiating basal plus regime, if the HbA1c is above goal, then what are the options we have for treatment intensification? We can add on other prandial insulins. That means we can add on prandial insulin with other meals of the day. First, we have added with the largest meal in the basal plus. Now we can add prandial insulin with the second largest meal of the day, and we can continue monitoring the patient and see the results. Okay, even still blood glucose is not controlled, then we can go on adding prandial insulin to all the meals of the day. That means we can go on with the regime which is known as basal bolus plan, right? Full basal bolus plan means basal insulin and prandial insulin with each meal. The second option, what we can do, if we have started the patient on NPH insulin at the very beginning, that means initiation of basal insulin, if we have started with NPH insulin, then we can shift the patient, or we can intensify the NPH insulin with addition of short acting insulin, that is known as self mixed or split mix insulin plan. In this, we will use NPH along with short acting insulin twice daily. How much NPH we will use? We will use 80% of the current NPH dose. 2/3 will be given before breakfast and 1/3 given before dinner. And how much short acting we will use? In the beginning, we will use 4 units of short acting insulin with NPH twice daily, that is before breakfast and before dinner, and then we will continue monitoring the patient and we will see the response. What other option we have? The third option we have is to add premix insulin. Okay, and premix insulin, there is already mixture of short acting and intermediate acting insulin which is available in the market in the form of 30-70 or 25-75, 50-50. We will add this premix insulin, okay, if patient is not controlled with basal or basal plus regime. And how do we add premix insulin? You can usually use unit per unit at the same total insulin dose, and 1/3 should be used before dinner and 2/3 should be before breakfast. And titration, of course, it is based on individual needs. That means we will start with basal insulin, then we will intensify it with prandial insulin, that is basal plus regime, and then again if we need intensification, we will convert it to basal bolus regime, or else we can use split mix regime, or we can use premix insulin, and then we will keep on monitoring the patient. As per the AAC, the algorithm for adding or intensifying insulin remains the same, but they actually specify the dose of long-acting insulin. If HbA1c is less than 8%, the dose is 0.1 to 0.2 unit per kg. If HbA1c is more than 8%, total daily dose of insulin will be 0.2 to 0.3 unit per kg. Okay, after addition of basal insulin, if glycemic control is not achieved, then we can go ahead with adding GLP-1 receptor agonist, or we can add prandial insulin. How to add prandial insulin? In the form of basal +1, +2 or +3 regime, or maybe fully conversion to basal bolus regime, right? So this is about how do we initiate insulin and how in a stepwise manner we intensify the insulin regime. Okay, this is the most important part of today's topic. What are the adverse effects we should keep in mind when we start using insulin? Hypoglycemia is one of the very important adverse effects. Only if the insulin is getting overdosed, means if the patient is getting overdosed with insulin, or if there is insufficient calorie intake. There may be allergic reaction with insulin. Edema may be there because insulin causes salt and water retention by acting directly on the renal tubule. There may be weight gain of around 2 to 3 kg after initiation of insulin, and there may be complication at the injection site. There may be a little bit of pain, or there may be lipoatrophy or lipohypertrophy. So these are certain adverse effects of insulin which can really be they can be counteracted with proper measure, and some of the adverse effects will become tolerable. For example, edema will go off after few days, like that. Advantages of insulin over OHA. So when we are prescribing insulin to a patient, we really need to counsel them, because there are lots of challenges while prescribing insulin. There are challenges from the from patient sides as well as from the caregiver sides as well. So we need to counsel the patient in the form that insulin has the most clinical experience. It is the first drug to be used for the treatment of diabetes. Insulin was invented in 1921, whereas the oral hypoglycemic agents came into market in early 1950s. Can be used which is contraindicated. Insulin provides better glycemic control. It is the fastest acting agent, of course, and it does not have an upper dose limit. Okay, all the drugs which we use, they do have a maximum dose limit. Okay, maximum tolerable dose limit, whereas insulin does not have an upper limit of its dosage. It has a beneficial effect on triglyceride and HDL level, and of course it has better tolerability. Now, once we have discussed about the insulin variety types and initiation and how do we intensify insulin therapy, now we can discuss about few cases. Like, for example, this case 1, where a 48-year-old male with type 2 diabetes mellitus has presented to us with uncontrolled blood sugar. For last 8 years, he is on metformin and sitagliptin, that is DPP-4 inhibitor. On investigation, his fasting plasma glucose is 190, that is quite above the range target, and postprandial glucose is 260, again much above target, and A1C is 9.5%. Fasting target for this patient will be around below 130, and postprandial blood glucose target will be around near about 150, yes, 90 to 150, and HbA1c below 7%. So in this patient, what should be our next best option? What best option we can choose in this patient? Patient is diabetic for last 8 years. He is on metformin and sitagliptin. Okay, that means patient is on dual therapy. Even after getting dual therapy, patient has uncontrolled blood glucose level, right, and uncontrolled HbA1c. So in this case, we will go ahead and start with insulin regime. First, we will try with basal insulin. We will initiate basal insulin first, and then we will monitor the patient. Once fasting plasma glucose comes down, PP also will come down. Okay, so we have to monitor the patient and see the response with the basal insulin, and if the patient is not getting control, then in the next step we can use basal plus regime, or we can convert it into fully to basal bolus regime. Of course, health education is very important, and counseling regarding insulin is equally important for the patients. Okay, and of course titration is important. We will monitor the plasma glucose level, and we will titrate the dose of basal insulin accordingly, and after 3 months we will repeat the HbA1c to look for the control. Second case, here a 56-year-old female has presented to us, okay, with uncontrolled postprandial blood glucose. She is on glargine 16 unit. Glargine is a long-acting insulin. That means she is on basal insulin along with metformin, right? So she is on dual therapy, that is basal insulin plus metformin. Her fasting is well controlled, that is 110. Her postprandial glucose is high, that is 210, and HbA1c is 8.6%, 6%. Now, what will be the best option for us? Now the best option, if we judge, it will be to add a prandial insulin before the meal where ppg is 210. Suppose the largest meal is lunch, and the patient's blood glucose which the patient has measured is after lunch, that is 2 hours after lunch. So we will add prandial insulin before lunch. Okay, we can add 4 unit, or we can add 10% of the 10% of the basal insulin. So 4 unit will be adding before the largest meal, and we will titrate the dose by 2 unit every 3rd day if PP remains uncontrolled, and we will keep on monitoring the patient. After 3 months, again we will check for HbA1c, and we will adjust the insulin dose accordingly, and if patient requests intensification, we can go on to fully basal bolus regime, or if the patient does not prefer 4 times injections, or if there is there is less chance that patient will monitor the blood sugar, then we can go ahead with twice daily regime, also premix regime. But again, in premix also patient really requires good monitoring. Okay, so this is about the second case. Lastly, spatial populations and spatial setting. In case of CKD and elderly patients, our target should be a little less stringent. Okay, so we need to add insulin at a lower dose, and we need to do slower titration, and we should prefer analogs because of their better action profile. In hospital patients, IV insulin should be used. In ICU patients, and basal bolus regime can be used in wards, whereas in ICU setup it is recommended that we should be using continuous insulin infusion. For pregnancy, human insulin is the preferred option, okay, and the targets are little tighter. That means stringent target is kept for pregnancy. So just to summarize my presentation, we need to start basal insulin when oral antidiabetic agents fail, or if the patient is symptomatic or the HbA1c is quite high. And then we need to titrate the regime as per the patient's need. Try to avoid hypoglycemia. We need to intensify with basal plus. If not basal plus, then with basal bolus or premix based on individual characteristics and individual preferences. And we need to address the barriers of insulin therapy, barriers from the caregiver side as well as from the patient side also. Health education is very important when we initiate insulin to the patient, and follow up, of course, means follow up has to be done. It means a very important part of the management of blood sugar when somebody is on insulin. Okay, this is just an example of weekly self monitoring of blood glucose log. Okay, so we can ask the patient to monitor the blood glucose when the patient is on basal bolus regime or premix regime in this way, and then we can modify the insulin dose depending on the patient's need and depending on the patient's blood sugar level. Thank you so much for your patience hearing. Thank you. I'm sure that this class will be helpful for the students as well as for the practicing physicians. Thank you.